Welcome to this presentation on internal bleaching. These before and after pictures show the kind of result that can be achieved, and we'll be talking about how. This patient had some perio problems, and initial debridement has cleared the problems up to an extent. Note how the gingivae have that healthy looking stippled appearance. The teeth have also been polished so that we can get an idea of their true colours. However, there's still a pocket on the discoloured root-filled tooth, and the question is this a combined lesion where an apical periodontitis related to pulp death has caused the pocket, or is it just a deep, regular kind of periodontal pocket? One way of telling is to gently push a gutta-perca filling cone into the pocket and get a radiograph. In this case, it's clear that the root apex is not involved, so there's every chance of success with a bit more perio treatment. So for this periotherapy, we need the pocket depth measurement for the baseline, then some initial deep debridement with an ultrasonic scaler. Here we're using a piezo scaler, and crucially, root surface debridement with Gracie curettes. At Dental Juice, we're pretty keen on the L&M Gracie curettes. Now, let's move on to the aesthetics. This dark incisor is too long, and for good aesthetics it needs shortening. And a really great way of checking what a tooth will look like after it's been cut down is to use a black felt tip pen first. If you can find a suitable volunteer among your staff, try it. You'll be surprised how convincing it is, much more convincing than in this greatly magnified photograph. Now, because the periohealing has not been completed, the tooth was left a little bit long. It's not unusual for a tooth with perio-infection to be slightly extruded, and this will allow for any intrusion that happens while the perio resolves. We can always do a little bit more shortening at the end if we need to. Next stage is to get access to the inside of the tooth. This will involve exposing the root filling, so dam isolation is mandatory. You really don't want to reinfect the root filling with saliva. The access cavity filling is removed, and the GP is removed to 1 mm below the gingival margin. This is important. If you don't do this, the neck of the tooth will remain dark after the bleaching has finished. Removing the composite from the access cavity can be really difficult, and thorough drying is essential. Etching the enamel will help identify composite left there because the enamel will go frosty, but the composite won't. However, this doesn't work with dentine. So it's a great idea, when you're filling palatal access cavities at the end of a root treatment, to use a shade of composite that's clearly different from the dentine. The colour and the lightness should be what the tooth requires, but use a composite with a high opacity. These are much easier to identify should one of your root-filled teeth ever need bleaching in the future. When the cavity is cleared, the exposed root filling must be sealed with 2 mm of RMGI. That's why it was cut 1 mm below the gingival margin. The tubule direction is slightly towards the apical, so this will ensure that the neck of the tooth gets bleached. A potential bad side effect of bleaching is external cervical root resorption. And if the hole in the tooth is too deep, bleach can be carried to the periodontal ligament via the dentinal tubules, and this increases the risk. There has to be a careful balance between having the RMGI too thin, where the resorption risk would increase, or too thick, where the neck of the tooth won't get bleached. After all the internal preparation, there will be a certain amount of smear on the dentine. A quick etch will remove the smear layer and open up the tubules to help the bleach penetrate. Here we're using phosphoric acid for 10 seconds, but other weaker acids will also suffice, like the polyacrylic acid found in Chemfil's dentine conditioner. Get the bleach ready. In this case, we used a commercial preparation of sodium perborate, which releases hydrogen peroxide. However, the European Union may have banned perborate by the time you watch this presentation, so you may be using carbamide peroxide. And in the UK, we can currently use 18% carbamide, which is the equivalent of 6% hydrogen peroxide. In this case, started by scrubbing the inside of the cavity with a runny mix of the bleach, washed out and repeated to ensure the entire cavity was fully wetted. Then a thick mix was placed into the cavity. You won't have this choice with carbamide as, well, the gel is the gel. Place a little cotton pledget over the bleach, and this will act as a sort of a stop to prevent the temporary filling from displacing the bleach. Finally, seal the cavity. Be gentle when placing the temporary filling so that the cotton doesn't get crushed and the bleach oozes back out. Some dentists recommend glass ionomer, but this will be difficult to remove, especially if the bleaching needs to be repeated at review. Also, when placing the temporary, the cavity walls are invariably wet. Calzinol, or any other modified zinc oxide eugenol temporary filling, copes well with moisture, but glass ionomer doesn't, and with GI your seal may be impaired. A week later, the bleaching has worked. This doesn't always happen. Sometimes the dentine has become so sclerosed and atubular that the bleach just doesn't penetrate, and repeat applications are needed. But in this case, we've got a good initial result. Palatally, see how the colour contrast of the calzinol makes identification really easy. Another good reason for using it instead of glass ionomer. But do remember that calzinol is quite weak and has to be 3 mm thick to survive. It's time to provide the permanent filling, so isolate the tooth with DAM, remove every trace of calzinol and cotton wool and wash the bleach out, leaving the glass ionomer plug over the root filling clean and clear. If you use an ultrasonic scaler to remove the calzinol, you won't damage the tooth like you might with a burr, and you won't also get that heart-stopping moment when the turbine hits the cotton wool. The eugenol in calzinol can interfere with polymerization of composite, so you should remove every trace. And now the composite is placed in the normal way, so start by etching. Dry the tooth, ensure that you've got a good frosted etch pattern. Apply the adhesive in accordance with the manufacturer's instructions, and gently evaporate the solvent. And sometimes you have to do this stage twice with certain adhesives. Then the light curing. Now, the first increment of composite must be thin. This isn't just to minimize contraction stresses, it's mainly because the curing light does not penetrate very well into the bottom of the cavity. So to be sure of a full cure, you need to use a thin layer. Keep adding thin layers and adapt them to the walls before each light cure. A ball-ended burnisher is pretty good for this. When you put on the final layer, try to put on just the right amount. Removing set excess is bound to damage the enamel, and the more excess you've got, the more damage will happen. Also, try to make the final layer thin. It's kind of tempting when it's sort of coming up towards the top to begin using thick layers. But as it contracts during setting, a thin layer at the top is less likely to crack away from the enamel. And I think we've all probably seen that little white line that sometimes form around a composite when it fractures, or to be probably more correct, when it causes the enamel to fracture from the setting contraction. Remove the dam and notice how this tooth is now much whiter than it was at the start of this visit. That's due to the tooth drying out with the dam, and it'll soon revert back. Make sure that the access cavity filling fits the occlusal scheme, and now the final length trimming can be done as the perio-healing has resolved. Remember to also round off the incisal edge to match the neighbour's profile. And when you're doing this, make sure that you're looking at the patient from straight ahead in a sitting down position face to face, not from the usual dentist's view from above the patient. The tooth would still benefit from a little cosmetic work at the neck, and where there's a cervical abrasion lesion. We'll do that at the next visit when the colour has stabilised. So at the next visit, colour's looking pretty good, and the filling at the back's doing well. So let's restore the cervical abrasion lesion. We would normally want some retraction cord for moisture control, but in this case we didn't use it in case there was interference with periodontal healing from the RSD that was recently done on the pocket. So, tooth is etched for 10 seconds with phosphoric acid, and you can see in the picture that a tiny bit of enamel is still left at the base of the defect, which will help adhesion of the new filling. The new restoration is placed, and it'll be reviewed in 3 months. Tooth will be reviewed to assess the periodontal healing and the final colour stability. Bleaching is an absolutely essential part, a component of the minimal interventionist's toolkit. Not long ago, the normal way to treat this kind of discoloration was with a post-crown or a deep prep ceramic veneer. But modern aesthetic restorative techniques, coupled with a minimum intervention philosophy, have provided long-term result that's met both the patient's and the dentist's aspirations. I'm Professor Giles Perrier, and this case was by Dr. Lewis Mackenzie. I hope you found the presentation interesting, and thanks for listening.